Good afternoon, and welcome to our Rotary Club Celebration of Service. I'm Ron Barnes, and it's an honor to be your president. We have a lot of guests today, so we'll get to introduce them in just a second. A thought for the day. A tree is known by its fruit, a man or woman by their deeds. A good deed is never lost. Those who sow courtesy reaps friendship, and those who plant kindness gathers love. St. Basil. Our reflection today, our esteemed member, Charlotte Zelo. And we have a microphone coming to you, Charlotte, so.
We're just making. I think we're going to forgo the video and just, it's ready? Okay.
Going to forgo the drum roll and the camera, or?
Yeah, just the dancing.
Today, I am going to reflect. This is truly a reflection. Recently in the New Yorker, there was an article about what our biggest challenges in the world are going to be. And they suggest that maybe the biggest one will be the problem of misinformation, malinformation, us not knowing exactly what we're doing and what we're talking about. And that's worrisome, and I think that's quite possible. But then I think here we are, the Rotary, looking at the Rotary pledge or whatever it is. Is it true? We should look at everything with, is it true? Is it the truth? Is it fair to all concerned? Does it build goodwill and better friendships? And is it beneficial to all concerned? Thank you. You all know that. That's good. That was a test. Okay. So I'm thinking today that we're in the middle of a mess here in Bloomington. And it's very difficult to get the facts to find out what's true and whether it's beneficial to all. I spent the weekend trying to track down what really happens, what's on campus, what's going on right now. And I heard somebody walking by as I got out of the car saying, "Boy, this place is a mess." And I don't think he met the papers on the street. And I think one of the things we absolutely have to work at, and maybe we need to do this as a club and as a community, a sub-community of the community, to make sure that when we talk about things and think about things, that we have the facts and that they're true and fair, because it's very easy not to be well informed. I will repeat this. It is very easy not to be well informed. It's hard just trying to track down what was exactly said last Thursday, Friday, Saturday I had a hard time digging it out. So I do think that we have a commitment to find out what's going on and why and what. Like the question of who brought in the state police, and were the local police involved, and were there really snipers on the top of the Union? And it turns out, yes, there were snipers, And no, there were no local police. There were no, the sheriff's department was not involved, no local law enforcement. It was all state. And it was brought in by the president of the university on purpose. And our local officials did not invite people. In fact, what they needed to do was to start a conversation. And I think we as a group have a lot of leaders here, and that we should take some effort to become perhaps messengers between the community and the people that are making decisions. We need that terribly, so that misinformation and outright lies and misleading stuff doesn't circulate, that we find out who really is where. I was in my condo downtown on Saturday noon and saw the helicopters. And at first I thought it was a hospital, but then I saw that there were two and they were going in counter direction. And I thought, that's state police. It turned out I had a hot dog stand on the beeline beneath me, which was run by a member of the city council, Kate Rosenbarger. And I tried to call her with my little my megaphone to ask if she knew what that was, and she did not. But see, a member of the city council did not know that the state police were buzzing around our city, while the state police, as it turned out, were literally knocking people down and hitting them. And I have some videos. I have some connections in the law school who are monitoring this, that there really was some violence perpetrated by the state police. So we need to know that, and we need to know why that happened and what we can do about it, because that's not acceptable. I say this as a reflection because 50 years ago, Jeff Richardson was here at the time. We had, did you get him? Harry. There was something that happened in 72, shortly after we were elected. Well, he wasn't elected, but we called him in. That was things to come, and said the campuses across the country were going up in flames. We did not want to be in the headlines, and Frank McCloskey and the city council and Jeff worked together with the student body people to go out on the streets with petitions for peace. And we decided we would be the city for peace. And if we had headlines, it would be the Bloomington, the city for peace. And we did not have any looting, any violence whatsoever at the time. But we opened the communications between the administration, the students, and the community, which is what we should be doing now. We need to know what's going on. We need to handle it with peace, with conversation, not with shouting and beating. And there is beating going on campus, which we do. So my reflection is, I don't want to see that again. We don't want a mirror of the past. We want a new slate. And I call on this club and all the power and force that we have here to help make that happen. Thank you.
Thank you, Charlotte, for sharing your wisdom with us. And it brings up the question is, how can Rotary get involved in those conversations? And I want you to know the leadership of this club is talking about how we might set up living room conversations or something else that will create an opportunity to have that discussion in a very safe environment to understand what is going on and look for solutions and help to bring calm to our community and our university. To introduce our guest today, we have Marilyn Wood.
Good afternoon. It is my pleasure to introduce our 14 guests today.
So if you would, when I call your name, just raise your hand or stand, and collectively at the end, we will give you a warm welcome. So today we have Ann Bright, guest of Jim Bright. Three guests of our speakers, Stacy Robinson, Teresa Rhodes, and Adrian Gardner. Gary Taylor from the North Rotary Club. Penny Githens, a guest of Jim Bright. Darren Patterson, visiting from Jasper. Aaron Parks, a guest of Sally Gaskell. Kathy Bayless, a guest of Jeff Richardson. Shelley Salee, and Cindy Brumbarger, guests of Raj Hadawi. Tiffany Finley, a guest of Tina Swanson. Jody Madeira, a guest of Jeff Richardson. And finally, Denzel Ross, a guest of Joyce Poling. So now, we are thrilled that you are all here with us today. And if any of you would like to know more about Rotary, I'm sure any one of us would be happy to invite you back again and tell you more. Any guests online?
Hi, Marilyn, and hello, everyone, and what a group of esteemed guests today. And I have to make a special shout out to my dear friend, Kathy Bayless. Hi. But we absolutely have esteemed guests online as well. We have my sister, Hillary Kahn, joining us. Hillary is the interim VP, Vice President of International Affairs for Indiana University, and she is also Associate Vice Chancellor for International Affairs at IUI. Welcome to my sister. And then also I want to welcome Raj from North Carolina and Megan Gearhart, who is joining us from France. So welcome to all. Thank you.
Welcome, everyone.
And congratulations to Megan Gerhardt. She's going to have a Rotary tour of Taiwan this summer. And we're just real pleased that she was accepted for this. Rotary birthdays. On the 29th, we have a young lady who hit her 90th birthday in Ruth Boschkoff. So Andrea Murray on the 28th. Happy birthday to both of you. Rotary anniversaries. Natalie Blias has been with us now for 6 years. A well-deserved applause for Natalie. Glenda Murray, 33 years in Rotary. Yeah. And Joyce Poling, 35 years in Rotary. Congratulations to all of you. Sarah Laughlin has an announcement to make. Sarah?
In other late breaking news about community service, we have an amazing opportunity to help a fellow Rotarian on June 7th. That's a Friday coming up, a month from now. There's going to be a national conference here in Bloomington of the Future Problem Solving International Group. And April Michelle is the executive director of that group. She's in the Melbourne, Florida Rotary Club. You've seen her here at Rotary a few times in the last couple of months. She's been around here a lot because the conference is going to be here. So they're expecting 2,000 students, 4th grade to 12th grade, and their parents and their coaches for this future problem solving conference. And I looked up to see what that was exactly, because I thought you might want to know a little bit more about it. Of course, it's a nonprofit, and it organizes academic competitions in which students apply critical thinking and problem-solving skills to hypothetical future situations. And when I looked it up, they choose 5, snarly topics every year that they have the students work on. And when we look back through the list of the last few years, it's all the snarly topics that Rotary is also working on. Clean water and sanitation, child and maternal health, peace building, local community development, and the other ones, environmental concerns. So it's really right up our alley, helping young people get the skills they need to address problems of a global scale. So where they need help on Friday, June 7th, kind of all day, from 10 o'clock till 5 o'clock in the afternoon, it's the day where the students present their action plans. And they've asked us to be MCs. How hard can that be? So, no painting, no foundation digging, no, picking up trash, bending over, just MCing. So it should be really fun. Lunch is included. I've put a few sign-up sheets around the room, and there's a sign-up genius that will be in the roundabout this week. So we need 15 volunteers. I hope some of you will be interested in joining me there, helping a Rotarian, helping these young kids get some problem-solving skills. It should be really fun. Thank you very much. Let's see those sign-up sheets. Where are they? I passed a few of them out to you. So there's several of them around the room, and I need them back so I can make sure to enter them. But if you want to sign up today, you can do that.
Thanks, Sarah. Also, hopefully you met Gary Taylor, Bloomington North Rotarian, who has the setup back here in the back when you came in, promoting a play that's going to be coming on June 21st to our community. But it's looking over the president's shoulder about a book that person was a White House aide for several presidents, and it kind of gives you a different view of leadership in the White House. So if you didn't see it coming in, take a look going out, because it's obviously worthy of your view. At this point, I want to introduce our program and ask Jeff to come forward to do that, Jeff Richardson. We've been talking about AMPATH for over 6 months as an organization. We're going to get a chance to hear about it today in full detail. So Jeff, join me.
Thank you very much. I'm going to go over a few particulars about our guest speaker and then go into a personal note afterwards. Adrian Gardner, medical doctor, master's of public health, is the executive director of the AMPATH program. And AMPATH stands for Academic Model Providing Access to Healthcare, and the director of the Indiana University Center for Global Health Equity. He's an associate dean for global health and an associate professor of clinical medicine at the IU School of Medicine. Adrian got his medical degree from Brown University and his MPH from Harvard. Those were his fallback schools. He couldn't get into IU, so just as a footnote. He traveled to Kenya as a medical student in 2001 during the time that the AMPATH HIV program was first being conceived. He returned to Kenya and served as the AMPATH team leader in 2006-2007. He joined the IU School of Medicine in 2012 as the executive field director of the AMPATH consortium and was based full-time in Eldoret, Kenya during his 7 years in this role. During this time, he worked closely with the Kenya program leadership to make strategic investments and policy decisions while also providing service to inpatients at Moy Teaching Hospital and Referral Hospital and outpatients at the HIV clinics. Since coming to Indiana with his family in 2020, he provides care for patients at Ekanazi Hospital in Indianapolis. So on a personal note, I first met Adrian during a donor visit in 2006 when I was working for the Abbott Fund, overseeing their international giving programs. AMPATH was one of our top grantees. Abbott, and then Abbott split into two companies, Abbott and AbbVie, still support AMPATH to this day. That makes AMPATH one of Abbott and AbbVie's longest grantees. And I mention that because in corporate giving, there's usually a rotation, 3-5 years. To have a grantee last that long is unusual. Since retirement, I've happily served as a volunteer on their development board. And I want to say, when I was in Kenya, that 2006, I went on an outing, bird watching, which I'd never done. Stick with me for a minute. There's a connection here. So bird watching with Joe Mamlin, who is the sort of iconic co-founder and leader of AMPATH, who recently retired, and Adrian actually took over for Joe Mamlin. So Joe is an avid bird watcher, knows everything about it. And there is a bird that flew by, which I learned was called a hornbill. And you know, of course, Adrian wanting to impress his new boss and also be of value there on the ground, made a sound like a hornbill. And of course, Joe Mamlin, Dr. Mamlin just rolled his eyes and said, "Oh, come on, be serious." And within seconds, the hornbill flew over and landed right above Joe's head on a tree. So that's one of Adrian's claims to fame. And he might, with urging, he might even give you a hornbill shout out. So AMPATH is one of the first global health programs to receive PEPFAR funding. And some of you recall that was George Bush's initiative with a lot of support from both parties that passed in 2003, but AMPATH was one of the first recipients of it. They have continued to get tens of millions of dollars from this program, in addition to NIH funds. So like $60 million for 5 years, $75 million for 5 years. So we're talking about, this is a major program. And I was in this area for almost 20 years. I can say unequivocally, this is the blue ribbon program, the gold standard. They take congressional people there. They take ambassadors there. They take people who are thinking about doing these kind of programs. They go to Eldoret and they go to the AMPATH program. And it's Indiana University, which is the lead partner. So not only are we doing great work here at the School of Medicine and at the school, but here also in Kenya. And he's going to tell you a little bit about this program now expanding to Mexico, Ghana, and Nepal. So I get choked up a little bit talking about this program because they are doing the work in a way that very few other entities are doing, and they have great results. So it's with great pleasure and honor that I introduce our guest speaker, Adrian Gardner.
Well, thanks so much for the generous introduction, Jeff, and thank you all, Ron, and everyone really for inviting me to be here today. I might just start with, okay. That's the hornbill sound. And maybe that I'll just leave it at that. So. No, again, so thank you very much for the opportunity to be here and tell you a little bit about the AMPATH partnership, which is a long-standing partnership. And you've already heard that I am really consider myself a product of this partnership, having come through as a student. And so I really owe my entire career and had a transformative experience as a medical student that really guided me towards my current professional activities. So it's really a program that means a lot to me, and pleasure to have the opportunity to tell you about it. So as you heard from Jeff, AMPATH stands for the Academic Model Providing Access to Healthcare. And it's really the name of a partnership, an institutional partnership between, as you can see in this diagram here, sort of a public sector health system or hospital, an academic health science institution, and this entity we call the AMPATH Consortium, which is a group of US, Canadian, and European institutions that have agreed to partner with the local academic medical center, if you will, along a set of principles that we really feel like defines an equitable global health partnership. And really the goal of the partnership is to partner to improve the health of people who are underserved and empower the local academic health center to serve those people that are mandated to serve. So we have this fundamental principle that we believe access to healthcare is a fundamental right. And whether you're living in rural Kenya or in downtown Indianapolis, should not necessarily determine your ability to access quality care. And this is a long-lasting partnership. We're now going on close to 35 years. And as Jeff said, IU has really led this effort and should be incredibly proud of this partnership, which is really now highly praised and sought after by a number of educational institutions as the model for a global health partnership. And as you heard a little bit from Jeff, that we are now expanding this model. The flagship program has been with Moi University and Moi Teaching Referral Hospital in Western Kenya, where we serve a population of about 24 million people who are served by that referral hospital and the public sector health system. And are now expanding this to northern Ghana, in Mexico, and in Nepal. Again, similar model where there's a local academic institution, local health system, public hospital that are partnering together to help improve quality and access to care for the poor. And AMPATH, importantly, it's not a legal entity. It's not an NGO. It's really a model of partnership that is designed to empower the local academic institutions and local leadership every step of the way. So the role we all play, and you'll hear as I go along here that we have IU faculty embedded in Western Kenya, a number of them, but they serve in these counterpart relationships where Kenyans are really leading everything. And we're serving as a partnership and with mutual benefit to our institution and their institution. So academic medical centers is probably something you're all a bit familiar with, but just to describe this a little bit more, and you can see all the US, Canadian, and European institutions that are currently part. There are now 15 institutions that are part of this partnership that have all agreed to work under the leadership of Indiana University. So you can see Purdue's on there. So if we've done nothing else, we've gotten Purdue and IU to work together. That's pretty good, right? But really leveraging the academic talent and the resources of academia and bring those to bear on improving health service delivery for the poor. Obviously, it's a medical school. It's now a college of health sciences in Kenya. So it has a nursing school, a dental school, a public health school. So really training the next generation of health leaders, both on the Kenyan side and actually on the US side. Again, I'm an example of that. Utilizing this model, we're really creating in partnership innovative ways of delivering care and then evaluating those and demonstrating how they can inform health policy to affect and improve healthcare delivery at a national level and an international level. So I won't go through all the details on this slide, but this is just giving you sort of a brief snippet of the impact of this partnership in Kenya, where, as I said, the referral hospital serves about 24 million people. And as Jeff said, we had this nice academic partnership that started in 1989, 1990 was the first class of Kenyan medical students. And then 15 years on or so, we realized we built this nice academic partnership in the middle of the HIV pandemic. And if we were going to be true to our mission of leading with care, then we needed to be responsive to the problem we saw in front of us. And really that's the philosophy of the program. It's not necessarily about a singular health issue, but this was a devastating medical pandemic that was destroying actually the fabric of society, including medical students at Moi University. And it was really a medical student at Moi University on the wards who had a very advanced case with multiple opportunistic infections that triggered in Joe Mamlin a desire or need to respond. And what started with individual philanthropy quickly expanded, and we were really nicely set up, as Jeff said, to take advantage of the president's emergency plan for AIDS relief, which started in 2003, 2004 under George Bush, and has been supported by bilateral administrations for the last 20 years. And so we are carrying now the AMPATH partnership with the Ministry of Health cares for about 110, 120,000 patients with HIV. We've lowered the maternal child transmission, and we've really expanded beyond HIV and transformed the health system in oncology and chronic diseases and mental health and maternal child health. And now working with the health financing system to try and make this ultimately much more sustainable. I'll just touch on these things in terms of, obviously this is an academic model that is not just about improving quality of care and service delivery, but also evaluating those and generating the research that's important to inform policy. So as Jeff said, we've had more than, it's actually I think now $250 million worth of research funding, much of that from the NIH that has come through this partnership. And now over 1,300 peer-reviewed publications that have been published from this. So not all that funding has necessarily been IU, because as I mentioned, there are 15 other partners, but IU has benefited tremendously from the research that we've done in Kenya as well. And it's really, the AMPATH partnership is really best understood as a platform, and we've been able to take advantage of that platform as IU to create an opportunity for our trainees. So we've had thousands, literally thousands of North American trainees, IU trainees going to Kenya. But we also insisted that every institutional membership of our consortium hosts Kenyan trainees, a principle of reciprocity and equity. not just sending our students, but really allowing their students to have a similar global health experience in our setting as well. So it's easy to get lost in the numbers, 110,000 patients, but I wanted to introduce you to one who's sort of a special person to me. She's got two names here because when I first met her on the wards at Moy Teaching Referral Hospital, as Jeff said, I worked there for about 8 years on the wards. This was actually, I believe it or not, after she gained about 15 pounds. She was pretty advanced, and she introduced herself as Samantha. She was Samantha in the medical record system because of the stigma associated with HIV. She had created a false name. And actually, it wasn't until several years later that I met her in a microfinance and fair trade organization that AMPATH had created to try and empower clients economically, and learned that her name was actually Florence. So this is not too long after. Got it. But I'll just show you what, many of you have seen, this sort of Lazarus effect that has been described with HIV once people can access the medicines that they need. This is, Florence a few years later, looking much more healthy. So we sometimes joke that AMPATH is the Indiana University School of Medicine's 10th campus. As you all know, there are 9 campuses around the state, but really, again, IU deserves an incredible amount of credit for having led this partnership and really set this up in an equitable way long before that was the popular thing to do. And it's really been the leadership of Indiana University that has created this opportunity for other institutions, some of which I trained at, as you heard from Jeff, that would not have been able to do this. And it's really, it's the Hoosier mentality and Hoosier humility that I think has allowed this partnership to be set up in a way that, that has really been impactful. So just to give you a quick snippet of this, how this works. So we have Indiana University School of Medicine faculty who are based in Eldoret, spend entire year or two, 10, 15 times living in Kenya. They're visiting lecturers at Moy University, and they work alongside their Kenyan counterparts in various disciplines. And you can see some of those departments that are listed there. And then Purdue supports a pharmacy team leader because their main collaboration is in pharmacy. And Mount Sinai, which is one of our other institutional partners, supports a team leader in adolescent medicine. And the University of Toronto partners with IU to support the maternal child health and OBGYN team leader. So I mentioned these are the 15 institutions that are currently part of what we call the AMPATH consortium. And again, led by Indiana, and they all agree to work under the leadership of Indiana. So part of my job is to herd these North American cats and make sure that we're all aligned and focused on the right principles and hold ourselves accountable to an equitable partnership. So just to give you a little more detail on the training aspect, again, I'm a beneficiary of this, but over 1,000 IU medical students and residents have done rotations in Eldoret over the years, typically an 8-week rotation. And we've had a total of 2,200 medical and pharmacy students that are participating in the exchange program if you include all the other institutions outside of IU. And we've had over 100 Kenyan students and residents that rotated IU, and again, an expanded number if you include all the other consortium institutions. And really, since the beginning of the medical school, Moy University established its medical school in 1989. IU faculty have been part of the fabric of that institution. So we've had IU faculty living in Eldoret, serving side by side with their Kenyan colleagues. And it's created this really long-term institutional relationship that is based on individual relationships, but transcends any individual partnership, which is somewhat unique in academic global health partnerships, actually. So many of you, I'm sure, are familiar with faculty who work one-on-one with an individual who lives in another country or is another institution, and their project ends, and it's like, okay, great, the project's over, we'll go on our way. And this is really different. This is really about an institutional commitment, helping to create over a long period of time, and no intent really to go anywhere, just to change the nature of the partnership over time. So I won't read these, you can read them yourselves, but I think, needless to say, I think that the impact of this educational experience has really been transformative for medical trainees. And again, I'm a good example of that as a medical student, went over and this changed my life because the HIV response was just beginning to be dreamed about. And I said, oh, I've got to do something about this. I've got to be part of this. And as Jeff said, I'm an infectious disease physician. So this is the catchment area of AMPATH Kenya, the 24 million people. We have over 300 Ministry of Health care sites where we support. And also, as Jeff mentioned, we've been the privilege of being the recipients of pretty distinguished guests, including Francis Collins, the director of the NIH, who brought a number of institute directors a few years ago. And this was the quote that he left on, I don't know exactly which platform on social media, but he was pretty impressed, needless to say. So I'm going to switch gears a little bit and talk a little bit about the Chamas for Change program, which is a part of the community-based programming that we support. It was launched in 2012, really based in response to the need that women in pregnancy and early childbirth were lonely and did not have access to the resources that they needed to help care for their children and to go through pregnancy. And it's this story about this program is actually best described by Justice, who is one of the program managers. And if we can, I'm going to try and show you this video because his words are more powerful than mine. Click one more time. Okay.
Daktari anatumia kifaa kilicho salama zaidi. Hata hivyo utasikia tu baridi na baadaye hakuna chenye utasikia tena. So tusiokope, twende tupimwe. Kliniki mnapoenda mnaenda watu wawili. Hata hospitali pia tukiukua twende watu wawili.
Nini nyingine tumejifunza leo? Yes ma'am. Amesema jinsi ya kuweza kujikinga na saratani. Tumejua hiyo sasa. Angusha. Ya pili angusha. Haya, sawa sawa.
My name is Justus Elungat Ikemer. I am a project manager. I manage MNCH innovations within AMPATH, but the main one that I manage is Chamas for Change, which is a 3-year program that takes women through the journey from pregnancy to 3 years. So it's we start working with women and providing health education in the community when they're pregnant and take them through the journey until the time that we provide them with a positive parenting aspect. And the program as well provides a microfinance aspect that tries to empower women in the community as well. As much as we provide education and talk to women generally about seeking healthcare services, we provide the microfinances because they will be able to save and loan as well as get money from this particular kitty to actually seek healthcare services in the communities.
Number 6. Number 7.
So this is a very, very different program, I would say that, because it's a combination of many things. First of all, this is something that happens in the community. Not many maternal and child health programs happen in the community. Number 2 is we already use the structures that are there. So we use community health volunteers who are already in the community. Thirdly, we just don't provide health education. We provide health education, we have a social aspect in it. We also have a microfinance aspect. Because when you talk to women about seeking healthcare services and you're doing nothing to empower them and tell them on how to actually get finances to go and seek healthcare services, sometimes it becomes tricky. So this model provides all that. I would say it's a good hybrid that provides not just education, but provides peer support as well. Most women you get delivering at alone. They don't have a company to go to the facilities with their partners, for example. So we try as much as possible to provide that model. So that makes this program special.
Sasa nataka nianze kwanza kuwauliza maswali ya kuwa, je, nitamuandaa vipi mtoto wangu kwa ajili ya kwenda shule? Nataka muone hii picha kwanza.
When we started the program, we told women to invite their husbands to come and join the groups, but the husbands initially refused. Then 1 year down the line, I was blamed by men for not including them. So that was a success story for me because in my culture, in African culture, having men come together and discuss maternal and child health issues and discuss NHIF and come together is always very tricky. Seeing men demanding to be part of the groups and part of the program is a big success to me. So yeah, to me that stands out. Apart from the other ones, the obvious, like we've improved indicators, we've facility delivery has gone up, and C visits have gone up. That is what we expected, and we've also as well empowered women because most of our women now have started their own small businesses that supports them in the community.
Baba toto akiuliza, mbona unataka tutumie mpira? Unaambia pengine uenda niko na kansa, yani kansa ya saratani karibu ianze ama niko na infection fulani. Tafadhali tutumie nini? Mpira.
So this is personal because I was born at home by my mom alone without any support, and I was actually beaten by aunts, and I'm lucky to be alive today, and I would not want any child to go through the same. So that's why when I started this program, I've been here for a very long time, and I don't think I'm going anywhere soon until I try as much as possible to save as many children as possible. Because I remember when I was in Bunyala one time, and a woman came to me and said, I don't know my child will be more disciplined without caning, because that is the culture. But based on the program, we talk to women generally about alternatives way of providing discipline. And the mother came to me saying, I didn't know this would work. My child is now even more disciplined. We are close to my children. My child has even improved in school. So it like that touched me. It's like this, to me, even when we started, it's like, this is not possible, because when we are growing up, we were beaten. And telling like a woman in the community right now, you have other ways apart from getting your children. It was not, I didn't even think of it. So that is a story that really touched me. As I said, it's a three-year program, and we started back in 2013. So we started in one sub-county, now we are in 11. And we started with 16 groups, now we have over 400 groups of women. I would basically say we are here because of AMPATH. The support we get from AMPATH leadership is tremendous, because without their support we would not be here. So we cannot separate ourselves from AMPATH because we are AMPATH.
So this Traumas for Change is really a really innovative and amazing way of delivering support for pregnant women and women who are raising young children. And it was co-developed by one of my colleagues at IU and actually the current dean of the Moi University School of Medicine, Julia Sangak, who is also a product of this partnership in a way, because she grew up as a medical student in the Kenyan institution at Moi and now is the dean. But this program has actually been evaluated pretty rigorously. So this was actually a results of a randomized clinical trial to demonstrate its impact. And you can see here some of the highlights from this. So the women that were included in these groups were more likely to attend 4 antenatal clinic visits, 68% more likely to deliver in a health facility, 98% more likely to receive a community health volunteer visit within 48 hours of delivery, and 74% more likely to exclusively breastfeed for 6 months. All indicators that we know are associated with better outcomes for women and children. So really a powerful program, and is essentially sustained now by the women themselves. So this model was really built on a existing part of the Kenyan culture, these trauma groups. And as you saw there, that includes microfinance activities. So it's actually women coming together and lending money to each other to invest in small businesses. And then they use that money to access the healthcare that they need, and they have this peer support at the same stage of pregnancy. And when this program was first created, it was actually, okay, we're going to take pregnant women who are all in the same stage of pregnancy, and that was going to be the intervention. And then 1 year on, they were going to disband and start a new group, and they said, well, all the women have 1-year-olds now, so they'd like to stay together and support each other through having 1-year-olds. And then the next year was, well, we're going to stay together and support each other having 2-year-olds, because we all have this, these new challenges that come with these various stages of child rearing, and learning about parenting together and learning from one another. So it really sort of took on an unanticipated demand from the community to continue. So this is where we stand today. We have now over 11,000 women who are part of these groups, over 857 trauma groups across 4 counties. And just to give you a snapshot. So this is one of the stories from one of the beneficiaries of this program. And I won't take the time to read it, but happy to answer some questions about this program and about AMPATH more generally. So, yeah, so this is the good parenting aspect of the program that I think we're launching and expanding now. So what's ahead in terms of the Traumas program? We're expanding to actually all the counties and also across the AMPATH network across countries. In terms of AMPATH more generally, we've set a audacious goal to try and train 20,000 healthcare workers. As you saw earlier, we train undergraduate medical students, but also postgraduate trainees, as well as community health volunteers, pharmacists, nurses, sort of across the spectrum of healthcare workforce. And to sustain and elevate the work in Kenya, that's obviously led by Kenyans, enhance the global operation. I'm going to stop there, and thank you again for your time, and I'm happy to take any questions.
All right, as I'm walking over, I suspect Raj Hidai has a question. Raj, do you have a question? I want to give you a chance first because I know the room's going to be full of questions. Raj? All right, Aaron?
I'm not sure he's on, Tracy.
Okay.
Hi. First of all, this is wonderful, and it just seems to fit perfectly with Rotary values and the Rotary model. So I want to express my support for it. Also, I have a public health background, and do you think there's something about the public health model itself that has shielded your organization or allowed you to grow free of some of the politics and some of the vested interests that are otherwise so powerful?
Yeah, you know, I think one of the things that's really interesting about working in global settings is that a lot of the fiefdoms and the silos that we experience here don't exist. And so they allow creativity and ingenuity, and they allow to do things that you wouldn't otherwise be able to do in some of the territories where we have things, you know, this is my job, or you don't get to do that because it's my space. And getting out into the community has been a really important aspect of the work we've done. Of course, we've strengthened the referral hospital, and I didn't mention a lot about that, but we've built, you know, Cancer and Chronic Disease Center that now houses radiotherapy and sees thousands of cancer patients every month. But it's reaching out into the community because even though it's an hour or two away, it's very hard to access that level of care many times because of the barriers that exist when you're living in abject poverty, right? So I think actually one of the important lessons we've learned from this is there are lessons we can learn from our global work that we can bring back here and apply in our communities here. And I think they're harder, it's not impossible, but harder to do here because of these fiefdoms and the politics you're referring to, where they sort of, you know, people have territories or health systems have geographies and things, and there's a little bit more space to be just creative. And certainly the need has engendered creativity in our Kenyan colleagues. And I joke, they're almost all entrepreneurs. Even our physician colleagues have farms and they're selling vegetables on the side. It's a real spirit of ingenuity.
Dr. Hadawi online.
Dr. Gardner, good afternoon to you, and thank you very much for coming to visit with us, as well as we appreciate what you spoke for, as well as the video. It was very impressive. As a retired physician in the past who had the chance to do similar thing on a local level, I feel that the program is beneficial, just like what you said. But is there any particular point you may have to invite us as a Rotarian to join you in whatever venture you would like our Rotary to be involved? Our Rotary has been discussing, like our president, when he said, we've been talking about it for 6 months or better. And we would like to see our contribution to work with AMPATH to be productive and add, hopefully, to what you already are doing. Could you elaborate what a role our Rotary Club might have in helping to expand your program and add to its value to the local community?
Sure. Thank you so much for the compliments and for the question. I think, you know, as you know, we've been in discussions for some time about what aspect of the partnership Rotary might help support or be interested in learning more about. I think it sounds like we're very aligned on it philosophically in terms of the focus of some of our work, and in terms of the desire to have long-term sustainability and really be helping to build systems, not just trying to come up with a quick fix, but really sort of in it for the long haul. So I think in particular the maternal child health work and the reason I sort of highlighted the CHAMAS program is an area where there seems to be a lot of synergy. And you know, the reality is these programs all started, many of them started with just an individual commitment of a relatively small amount of money that just stimulated and gave the pilot funding that allowed someone to start something. and have then, again, our HIV program started with one medical student, with one person getting antiretroviral therapy. And it's this sort of catalytic investments that we need that allow us to do this in a flexible way to take advantage of the Kenyan leadership and the American leadership working in a collective way to bring to bear these large, now huge programs that are impacting hundreds of thousands of people. So I look forward to further discussions, I think, with your group about that.
Great, Steve.
I just wanted to thank you for this admirable effort. It's just a wonderful program. I'm just curious how it's all financed. It sounds rather extensive and expensive.
Yeah, so again, it started with not a lot of money, which I think is maybe part of the reason it's so successful, because it attracted people who were interested not in the money, but in the impact of the partnership. It started really just a commitment by IU to put a faculty member on the ground and help to build a medical school. Over time, it has grown, obviously, in tremendous ways. And as you heard along the way, it's individual philanthropy has been a huge part of this, corporate philanthropy, and of course, government funding from USAID and large foundations like the Gates Foundation and others. And a lot of the research has been funded by NIH. And of course, NIH is not supporting, improvement of care delivery necessarily, but increasingly is supporting the implementation science that is demonstrating how improving quality can impact and be important at a policy level for showing, demonstrating the outcomes that such interventions can have. So it's a pretty sizable operation at this point, not controlled by any one individual. I mean, I think there are the PEPFAR funding in and of itself right now is close to $25 million a year directly to the Kenyan institutions that are implementing this HIV care. The NIH research funding is somewhere in the order of $20 million a year. So it supports individual research projects that are under this umbrella. There's the platform, but a lot of and then the corporate and foundation support that we get for improving care systems and demonstrating impact at the community level and at the referral hospital level, improving cancer care, for example, and building on this partnership in new ways is a combination of sort of corporate philanthropy as well as individual philanthropy. So the entire Center for Global Health Equity at IU, and we sit within the Department of Medicine, within the School of Medicine on the Indianapolis campus, is run on that kind of philanthropy that was championed by my predecessors and created endowments that allow us to continue to function and support the faculty that are embedded in Kenya.
You may want to shout out to Lily.
Yes, Lily has been an enormous supporter of the Lilly Foundation, as well as Lilly Corporate. We get, in fact, I got an email this morning that the latest shipment of product donation, mostly insulin, but also mental health drugs, arrived in Eldoret yesterday. And yeah, they've been a huge supporter, something on the order of $20 to $30 million worth of product every year.
And for our last question, Charlotte.
Yes, I used to work for Planned Parenthood, and that has been seriously derided in this country. But the purpose of Planned Parenthood was planning. And it sounds to me as if you're in a position to help women plan their pregnancies, and that would contribute very vastly to better outcomes and better use of resources. I just wonder to what extent you've directed your resources and activity towards making sure that pregnancies are planned and then you can supported before the birth of the child. It seems to me that's a really reasonable way to do that.
Yeah, thanks, Charlotte. I think it's really an important aspect of it. There's no question that it's a complex issue, as it is the world over, in terms of the gender dynamics that play into whether a woman has the ability to dictate when she's going to become pregnant or not, and how to access the prenatal care and every step of the way. So it's certainly improving access to contraception and giving people choices about have been a big part of our efforts in the maternal child health space. And also, many women are delivering in the community. As you heard from Justice, was born in the community, not necessarily anything, wrong with it, but we know that delivering in a health facility leads to better outcomes, right? So if there's a complication, so we've put a lot of effort into getting people into healthcare facilities at the time where they're most vulnerable to try and intervene, and particularly with the HIV epidemic. We have drugs that can prevent the transmission of HIV from mother to child if we know early enough. So if we can diagnose HIV early in the pregnancy and get people on those medicines, we can prevent that cycle from continuing. So thank you so much. Thank you.
What a wonderful program. And again, I'm sure the doctor will be around for questions that you might have. He'll stick around a little bit. We're getting a photo Kodak moment here.
Work with me.
A donation will be made in your honor to Hoosier Hills Food Bank. So we really appreciate your presentation and bringing clarity to a discussion we've had, as I said, for many months. Some acknowledgements, obviously. Steve Engel was our greeter. Marilyn Wood introduced all our guests. Thank you, Marilyn. Joy Harder, who's our Zoom host. Charlotte, for your wonderful reflection. Our reporter, Amy Kendall. This is, I believe, she drew, I think this is the 5th Tuesday, so she had a long job when she took on this role. So thank you for your work. Tracy, as your camera and mic operator, and obviously Tyler for the work you do. Our next meeting will be back in this room on May 7th, and our speaker will be Jerry Massey, speaking on sculpture trails. That ought to be very interesting. If you would stand and join me in the 4-way test. The 4-way test of the things we think, say, or do. First, is it the truth? Second, is it fair to all concerned? Third, will it build goodwill and better friendships? Fourth, will it be beneficial to all concerned? And fifth, is it fun? Have a great week.
Yeah, is this still on? Just a quick announcement for everybody. Just a quick announcement to everybody is that we will be having a meeting here about AMPATH. If you would like to join us, we're having our committee meeting over here. Okay. Hello, everybody. Oops. Hi, Raj. Hi, Lexi. We're still getting ourselves together here, and it's going to be a while before everybody can hear because there's so much noise in the room. But it's going to be about 5 minutes before we can assemble everybody to the table. You can see here's the table, and there's nobody there. And here's everybody chatting with each other. So it's going to be a little while.
We need a beer. You're right.
Okay. So Raj, we're here and we start the meeting. He doesn't know it yet. I can do it. Okay. Yeah, I just think all the committee together. Dave? Dave. Yeah. International scale. And you work with So Raj, we're here now. We're starting the meeting. We've got Lexi here as well. Okay, just keep going.
What I'd like to do quickly, just very brief introductions. Obviously, for Adrian, Steve, they see what the differences in
Oh, hi, I've met most everyone already, but I'm Teresa Rose, and I work with Stacy and Adrian about 5 years at the IU Center for Global Health Equity, and I'm part of the development university team.
Hi, and I'm Stacy Robinson. I think I met most of you as well now. And I've been with the center for about 4 years, and then with IU in a related position for almost 9 years now. And I'm work with Adrian as well. And I work, my title is Director of Partnerships. So I do a little bit of working with our new sites that are being developed, as well as with our population health team, which is the trauma serving part of
Very nice.
We heard from Raj.
Right.
And then Alan, you want to-
Yes, I'm Gardner. I've been part of the Rotary Club for many years now. I was president 2 years ago. So I work in the music world, but I'm very involved in community work. And I have a passion for community health in my personal life.
Oh, and I forgot to mention I was a Rotarian.
Okay.
Yeah.
And I will say that in terms of this project, Alan has been our vision person. He's the one who's, as I'm thinking checkers, he's playing chess. But he has developed, he's been active locally in a sibling city program. And one of the sibling cities is Palo Alto. And as he's thinking ahead, Stanford being part of the consortium, thinking ahead, it's a great election.
Sure. Thank you. You're very kind.
And Jim is the one who leads, it's a really a state with the global scholarship. So the Rotary districts of Indiana at this point are funding a $40,000 postgraduate scholarship.
I'm Ron Barnes. I've been in the 40 years. I started when I was first graduate.
40 years.
But these folks have to go eventually back to work. I'm going to stop talking here.
Okay. That's Charlotte. Steve Wicks on the current head of the International Committee.
Darren Patterson is from Jasper.
Wow, that's great.
And we have Rashid Ali online. Who we met earlier on.
All right. And then Geronimo.
Geronimo Ratti, School of Public Health, Kenya, Ontario, love what you're doing.
Okay. Before we start asking you questions, do you have any questions of us? Okay. I will say that the Rotary Universe, what we've been working on is a project with our Rotary Club and AMPATH, but when I talk about the vision is to grow that into something bigger involving other Rotary clubs, involving the district, involving Rotary International, maybe some outside donors. And the universe for those Rotary level grants start at 30,000 and go up to 400,000. Okay, and then the next universe after that is Rotary has one grant a year. That's a $2 million grant that comes out of Rotary International. And then at the next level, you have Rotary International with relationships with the Gates Foundation. So right now, I think for the last 3 years, Rotary's been putting out 50 million to Gates, 100 million to eradicate polio. So we're just this little bit, but there's this big universe out there that we'd like to kind of tap into.
And the other thing that I want, that's great, it's a great representation. The thing I want to mention is that we've been around for years as a Rotary Club.
Can you guys raise your voice for me? I don't hear you barely.
Okay, sorry about that, Raj. So we've been around for about 100 years, and we've never strategically linked our efforts with Indiana University, which seems completely crazy given the positioning of the club in this community and the number of Indiana University faculty, administrators, and what have you, who've been part of this club for years. And so we're interested in modeling not only the sort of granular sense of what it would be to forge a relationship that has the potential to expand, but also to model the possibility of Rotary clubs connecting with academic institutions. So it might be interesting for us to look at the Rotary clubs in those cities associated with the AMPATH project to work out if there's a collaboration that we could develop there as well. So it's this idea of starting small, proof of concept, that has the potential to expand in those two directions, both in the Rotary system, but also this idea of leveraging the relationship between Lovington Rotary Club and the university.
Charlotte has to, I just have a comment. There was a time, maybe 20 years ago, when a bunch of people in the community said this is way too university oriented. And they left it for me. So that was not it.
Okay, yeah, so Raj, Charlotte just mentioned that there have been discussions about the Rotary Club and Indiana University fast. And whatever you can't hear, Raj, you and I can have a conversation online, on the phone later on this afternoon. I can tell you what was said. Okay.
So Rotary International, three areas, humanitarian projects, vocational training, scholarships. Probably scholarships have the fewest strings attached. But in terms of your presentation today, you talked about the Chalmers program that you had approached with us earlier. We got a little bit skittish on that because of the micro lending aspect. But then it almost seems like the Chalmers and the community health system very, very tied together. So you talk a little bit about that.
Sure. So, I think one of the things we've seen, not just in the Chalmers model, but actually we have group care like that for diabetes, with HIV. And one of the things that we've really, it's been pretty consistent across the board, has been the power of this microfinance piece to hold and bring people together, right? I mean, these are as Dr. Ratish knows, women that are living on, $1 a day or a couple dollars a day, right? For all their needs, housing, school fees, food, you name it. And so they don't have access to big capital. They can't take loans from banks in formal, ways. And yet they want to start a business, or they want to start, something sustainable, or they've got school fees to pay. They have these needs. Their ability to lend to one another and to generate income that way is really a powerful force that brings them together. And that bringing them together then creates a platform for healthcare delivery or healthcare education that has been sort of something we've taken advantage of, if you will, in maternal child health, in diabetes care, in cancer screening, and HIV care. So it becomes sort of this model of pulling together health and microfinance together. It's really sort of a nice combination of bringing people together and keeping them together, because everyone's going to follow their money, right? These are, they're paying their dues, and they're getting the opportunity to take that money. They're going to come every time. And of course, that's one of the, universally, one of the big challenges with chronic disease care. And, even in the US, 30% of people actually take their blood pressure medicines, right? And show up to their appointments and things, right? So if you can get people just to come consistently, then you have the opportunity to intervene in a way that is pretty impactful.
Chalmers creates an institution or an organization that probably allows community health promoters to do their job more effectively.
Yeah, exactly. And community health promoters are going house to house, but things are beginning to evolve in different ways. But they used to be truly volunteer. I mean, nothing, right? And so and yet people would say, okay, the community health volunteers are the solution to this and that and this, and they've got to give the polio vaccines, they've got to deliver the malaria treatment, they've got to do it. And the reality is, if a volunteer, there've actually been studies on this where they work about 8 hours a month, right? If they're truly volunteering, because they have their own needs and their own families and their own. And so the Kenyan system is really trying to evolve into community health promoters now, is the new term, being a formal part of the health system, where they're actually paid by the counties. But they have been dependent on essentially their own means to deliver this. And what this group allows them to do is, actually the women in the group value the health education the community health volunteer brings. They actually can pay the community health worker to come to their group, and they can do that out of the sort of the profits of the group microfinance activities. And so they, or at least, subsidize the cost of the community health volunteer. What kinds of businesses? Well, you name it. I mean, a lot of them are farming and chickens and selling fruits and vegetables.
One thing what is very unique about the Chalmers is that even my own family, my sister-in-laws and the husband, they have one. They're very strict with attendance. If you get late, you get penalized. Those are the only things that I'm saying people going on time. Get penalized for coming late. You get penalized for missing. Okay.
Raj, we're just moving over, moving the table so people can hear better.
Much better.
Okay. You know what I'm going to do is I'm actually going to rove with this
So Raj, okay, here we go.
I hear you now very well.
Okay, good.
I heard Adrian well.
You heard
but
what, sorry?
Adrian Garner well,
Yeah,
but
okay.
not the questionnaire or the
Yeah,
comment.
so I'm gonna just walk around with this so that you can hear people.
Thank you.
So, yeah, right.
Hey, agility, man.
I love it. Yeah.
Okay. So the proposals that we have on the table for AMPATH, one was a need for $5,000 for the Sally Test Child Life Program, refurbishing the kids' room, or what's the what? Toys. Yes, yes. And that some group members at our last meeting supported that. Frankly, more supported the $10,000 for training 150 community health promoters with a weekend training, and some of the things involved with that. And that was supported by a slim majority. I think since then, we've kind of come more in that direction, and less in the Sally test. The other thing that I'll throw out, not to make it more complicated, is for $8,000, that will pay for the cost of one Kenyan student to cross-train at IU for how many weeks, how many months? Like 8 weeks. So.
Yeah, it's for the Kenyan, for medical student or registrar resident income. Yes, yes.
So. And part of the questioning we had was want to make sure it's measurable, because we want to, as Stephen alluded to, we want to make sure we can demonstrate so we can get other clubs to join it.
So what is that from? Unless travel and what?
Travel and their housing.
For 6 months or 6 weeks?
No, 6 to 8 weeks, right?
But it's kind of one and done, and then we wait a year and do another one. And that's, I mean, I think it's fine, but then it's a different kind of ongoing relationship, right? Because we still follow that doctor and see how she or he does and see what progress they're making. And it's a more personal kind of journey that we're tracking. Where the shamans, there's more storytelling potential, there's more transformative kinds of things that may happen. Not to suggest that one of these doctors might not have his or her life change, a la Adrian, but I mean, a lot of these folks, I assume, correct me if I'm wrong, the fact that they got into this program already, fairly, I won't say fast track, but they're merit-based. They're doing already well. So I don't know. I think there might be more of an appeal with the shaman's program, where it's ongoing monthly updates or quarterly updates. Incidentally, very mindful of our staff. Stacy, that we don't want to do anything with this very initial modest grant, asking to do a lot of work. This would be piggybacking on existing reporting. You folks telling us what might be a nice story that you're already getting, that you already, or if you have like kind of moth kind of things, right? And storytelling, things that we can pull out and report. But then as we get more ambitious, as Steve said, years from now, something very dramatic.
I think part of the
look for more.
Yeah, and part of the trick is to find out how, in a granular sense, it can be tangible. In other words, how are we doing something? I know that absolutely, with the sensitivity in mind in terms of not wanting to get in the way, how can we design it in such a way that it feels like it's meaningful, tangible, relatable, so that it can be used as a stimulant, as a catalyst for growth in a way that feels strategically manageable. So that's really sort of, threading the needle. That's what it is that we're looking for, is a way to engage with this so that it shows a proof of concept and has the potential to grow in a way that is compatible with the shaman's program or whichever program we're engaging with the idea that there's this opportunity, there's this horizon for growth and development. But without one, you don't have the other. In other words, if it's not something that individual Rotary Club members can relate to, it's difficult to motivate them to get involved.
And then also, I'm looking at opportunities for growth as you talked about public health and getting to the community. When I look at the chairmans of the community health promoters, there is actually an avenue for us in public health to get involved. In fact, right now we have 5 PhD students who are in Kenya, who are in Kericho, they're doing interviews with community. That would be something that we can bring in the universities, and some of us can travel and say, hey, let's do it. Let's go for a week and do education and do interviews and do health promotion on different topics. So I can see that is a very seamless where we can bring in different faculty, different institutions to actually continue and to build onto our stories and what we're doing.
So long as we don't get in the way.
Yeah, exactly.
I think that's the critical thing.
So Jeff, are you suggesting that we step back and go back and take a strong look at the CHAMAS program as opposed to selling tests for the community health promoter training?
I just felt that the Sally test, I mean, I was one of the people that liked that program. Incidentally, they just got $1 million grant from a donor, just FYI. So that's good news. Yeah, but you know, I think it was perceived like Toys for Tots or something. It was too, for some people, to not substantive enough. But it is a child life program. There's many components to it. But I think, you know, I defer to the AMPATH folks as well. But you know, I'm open to either pathway, but it felt like we were leaning towards the Shaman's program the last time we met.
Community health
promoters, yeah.
Okay, so that's where you're
right.
But I think at this point, we're open to whichever direction you think we could go. I mean, I think that you're getting a pretty good sense of what we're trying to do here. You know, develop a proof of concept that is relatively small scale, but then, you know, be very committed to building it in a large scale and think of how we can get there together as in a partnership.
So I think I've mentioned I've previously been a Rotarian, and one of the projects that I got involved with, I'm actually no longer an active Rotarian. I might rejoin eventually.
Please do.
Yeah, I'm fallen Rotarian.
Collapse.
But one of the projects that I got involved with that I really became passionate about while I was a Rotarian, because we had a World Community Service Club, was a program that trained local volunteers on education and providing those types of opportunities. The way that we approached it, though, this organization that I became involved with, which I'm still involved with, even though I'm no longer a Rotarian and actually sit on the board of, was more about like advocating for the work that's happening in the community and lifting it up, knowing that I am not going to be a person who can go in and train people in Latin America, but I can support the people who are. And so that's how that organization operates, is giving us the way of like continuing to advocate for them, support them, supporting the good work that's happening. And so I could see this evolving into that, because the community health promoter program would be supporting those community health promoters who are going and training the CHAMAS groups and training the women. And so by providing this, it's an opportunity to support their work. And then at a later point, you know, rather than calling it a service project, we did an advocacy project, so we could have Rotarians visit and learn more about the CHAMAS program and how it's working, and maybe like think about, oh wow, this is something we can start here in Bloomington. Yeah, and like sharing it with other people.
And that's exactly what I think, and Raj, I don't want to speak on your behalf, but I think you and I were aligned on that approach. Teaching them to fish essentially is the way it felt like. Exactly what you're saying with community health promoters is that we're helping them grow and expand and get better. And so that's why I think we were leaning, at least Raj and I, but I don't want to speak on your behalf, Raj.
He's talking.
Oh, Raj, I'm sorry. You're trying to say something and we can't hear you. Apologies.
You call me when you're ready for me.
Yeah, we're ready for your. Go ahead, Raj.
Dr. Gardner, if I call you Adrian, you don't mind that, do you?
Not at all. I prefer it.
Thank you. Well, the presentation of today, particularly that video, told me two things. You activate the Hippocratic Oath for all of us physicians, which is the well-being and health, actually very close second to the do no harm. You cover all bases for us. But I would like you to elaborate for me and for the committee. Number one, how do you choose those people you would like to educate? Number two, what is the percentage of them to succeed indeed to apply what they learn in the community? And finally, do you compensate these volunteer, what you call volunteer? When we say volunteer, we know what volunteer in America are, but not necessarily volunteer in Kenya, because it's a whole different culture, different education, et cetera, et cetera. You know these. So concentrate for me so I commit myself if I know the process of choosing the people you educate and how much they carry that mission out to the community. If it's all of them like the video you showed us, that's a home run there, but not necessarily so. And thirdly, indeed, if the community respond to the message, you pass it along to the volunteer.
Make sure I caught the beginning because I missed one word at the first time. But I think you
yeah,
said about
okay.
how the community health promoters are chosen. Is that right? The first question.
Yes, how you choose them.
Yeah. So we don't choose them. I mean, they're chosen really by their communities, and they're members of their local communities, and they're identified by there's sort of a tribal structure, a local chief, and they're chosen through that mechanism essentially. And they're identified as a resource, and it's a source of pride for their communities that they become a resource to their community in that way. As I alluded to, I think that the program is primary healthcare delivery is under sort of reconstruction, if you will, in Kenya right now. And there's some new models being rolled out, and part of it is elevating these what used to be community health workers or community health volunteers to community health promoters, and make them a formal part of the workforce. The implementation of that has happened in sort of with some variability across different counties because the health services are devolved in Kenya to a county level. So all the health employees, health workforce within a county works for the county. So some counties have brought them on and assigned them formal employee numbers. I mean, to give you a sense of this. The stipend that a community health worker used to be assigned was $20, essentially 2,000 shillings per month. $20 a month, and then a bike and some materials, a bike to get around, and some materials to do the health education. So I don't know exactly what the new rates are going to be in terms of the new vision for how much a community health worker health promoter is reimbursed. But that system is sort of evolving as we speak. As health financing is also sort of health financing.
So I'm wondering. Go ahead, Charlotte.
My question is, I look around and this depends on some involvement of this community, right? This community, right?
Not necessarily.
Why are we doing it?
Well, our involvement would be paying for it. It's possible that Gerono on her trips to Kenya, maybe others can provide input and learn things. But I would say this would be fairly hands-off in terms of from club standpoint. Do others see it the same way?
I would add on, well, for physical labor, yes. I would say that going back to what Alon had said earlier, it's about the partnerships and working together as a community with IU and potentially with Palo Alto, and how we grow and support, much like we do other programs within Rotary. So we are maybe not actually doing the labor, et cetera, ourselves, but we are certainly supporting and creating that community.
My concern about this community is that there's mushrooms growing up.
Tracy, can you repeat that?
She's worried about how there are different, and here in this community specifically, you have microcosms or mushrooms growing up all over because you have multiple new efforts that spring up within Bloomington, which is true.
Right, and that's why we're considering this at such a deep level. I mean, I think that we're thinking through a lot of scenarios right now, and I think that the outcome of this meeting hopefully will be a commitment to work with AMPATH on a model that we think will work synchronized with the club in a manageable way over the next year. And I'd say just give it a shot. You know, at this point, I think we've been talking about it for a long time. I'd love to see it consolidate into an idea, an implementable idea, and then just give it a go and see what we can learn from it.
And the one thing we haven't talked about, and John has been very helpful, and we're also linked up with the Eldoret Club. So we're working with the Rotary Club there as well.
Yeah.
And that is critical to having eyes on the ground, so to speak.
And that's a lot of what we would lead. We would lead our communication with the Eldoret Club.
We're not going in mushrooms, so to speak, because there is an existing one. So what we're doing is embracing an existing
And empowering
program
it.
and empowering it. But I also think that we're going to have Kenyans coming in, as we just heard,
Yeah.
in Indianapolis. So we can go up there, they can come down here.
Yep.
I mean, we're literally, when I heard about the previous international program, it was a small program in the Democratic Republic of Congo.
You're right.
Yeah, I mean,
Yeah, no, you're right. I mean,
there was no real connection.
the opportunities for relationship building on any number of levels that we have yet to discover are enormous. And so I think it's important for us to just simply say, let's go for it and establish what we mean by that. And then just, try and get it down to that simple move. Right.
Yeah. So I have a question for Adrian, and this is my crazy idea. If we start with one chama, and then that way we build that, and I've seen models where we have one chama, they grew, and then they mentor the next one, they grew, and then they mentor the next one. What is it going to take for us? If we say we want to start with one chama, and then maybe we can have a community health promoter working with them.
My understanding is that from the dollar standpoint, that the budget for a single chama is mostly micro. Do I have that right?
Yeah, I mean, the need is really it. So we have a team, an AMPATH team, that supports the creation of new chamas, right? So they're going out and they're mentoring the community health worker, and they're mentoring the leadership of the chama on the microfinance activities and helping to create new groups. I don't know that, I mean, the cost of starting a single group is, I don't know if I can even calculate that, because I think it's supporting the staff that are supporting multiple groups.
So, and with the idea of exactly how we're going to do this, would it make sense for us to liaise with the two of you, or how do we take this forward? If we moved in the direction of, say, for instance, the chama option, what would be the way to get there?
Yeah, I guess to back to you guys to some degree, like, do you solicit proposals, or what's in terms of getting into the weeds?
We've just been sharing ideas, and then we could build a concept, together.
Yes.
I want to try and keep it as simple as possible. I just feel that once we decide to move forward with this project, I want to distill it down to what we really are trying to do, and then extrapolate from that, rather than looking at all the options and going around the block, 5 times more before we make a decision.
On the chama proposal, would it make sense to maybe undertake the financing for the expansion of chamas to a particular geographic area, where we come up with an estimate of how much it would cost in order to reach an area that's not a community that's not being served, and that would be the Bloomington Rotary Club's contribution for year 1.
But I think, just to make sure, though, that the dominant financial need is seed money to get the micro lending going at the new chamas, correct?
Yeah, so I want to take a step back, maybe for circling, yes, or swirling. And the reason we didn't want to do the chamas initially, the micro lending gives us hesitation, just because the word here in the U.S. it's mixed. And so that's why we went back to. I think we can take the one off the table about the one student, because I think that was short-lived.
So I think the health navigators.
We just need to make
Sure.
decisions.
Yeah.
And so when I hear your story, Stacy, with regarding to the promoters, promoters, that sounds like that's a good one. It sounds like the other one was the.
Yeah.
Okay. So I want to keep us focused on, because we already went around. So why
Yeah.
we are against those two. So let's stick with those two and listen to what we've heard here and make a decision.
Which two do we have now?
Well, we have the community health promoters, the 3-day training for 150 people for $10,000. The child life program, Sally test refurbishing, which was 5,000, which was less popular. And then we've really kind of circled and kind of revisited Chamas a little bit. I threw out, footing the bill for Kenyan students coming to the US for 8 weeks, but I'd like our guests to make a comment and then I'm gonna make a motion, so go ahead.
I had a question regarding your idea about reciprocity. So you mentioned that you would bring, is it young doctors here? Okay. Or medical students here to see what our system's about. And then the reciprocity would come that we might bring some of our students to your location. There is a program through Rotary that's a Rotary Friendship Exchange. And I think that might be something, I'm just a guest here. I'm just throwing some ideas on the table, but that program is already, that program is already in place. And that's what it sounds like, that we would send folks to your location and vice versa. And then the sponsors or the hosts could be the Rotary clubs themselves as a natural way to connect. So there's already a Rotary program established for that. And it was funny, starting a new club, and got started on a club in Jasper, and I'm out recruiting new members and meeting people. And I just had dinner with a couple, and the gentleman was from Kenya. So I'm like, oh, wow.
Okay, wow.
Kenyan exchange. Maybe you would be interested in maybe connecting there. So that's all I had to say was maybe that program that you're searching for already has somewhat of a foundation laid by Rotary. And that's been in place for about a decade.
What he's doing is really cool because he is starting a new club based on a common interest as opposed to solely geography. So it's not a club for people who just live here. It's a club for people who have a common interest.
And I'm traveling to Germany. Traveling to Germany Monday. So my goal there is to find a club in Germany that would want to be a sister club, so we could facilitate exchanges for young people to do professional programs, learn about culture and business and so on. So that's my thing. But I thought, oh, this sounds very familiar to what I'm trying to accomplish with my group. So thank you for letting me.
Hey, before you do, let me just make a quick comment. I think we misunderstood the Chamas program. That we are not really giving money because I've been a member. You just come together. You saw them calling the numbers. Number 7, we put 10 shillings there. Number 10. So people bring their own money and they say, okay, today the money goes to you. We bring all our monies, it goes to you. So no one, we don't have to. We're just helping to set it up for the meetings, but we are not giving money. They come up with their own. So I just wanted to say that there was something
involves, right?
So I think that the original, is it, okay, I want to clarify.
That's not to clarify that yet.
Okay, so the original proposal that when we reached out to the population health team in Kenya and they said what would be most helpful, they said it would be nice for some of these groups that don't have as much money to have a little seed funding to get them started for the microfinance activities. So that was kind of an original, but I think that all of you said that didn't feel like a good fit. And so then the other alternative was a training program for community health promoters who would then implement curriculum that's focused specifically on positive parenting into the Chamas groups. So it'd be CHPs who are like already part of them, but giving them these additional skills that then they could share with the women.
And that was the idea.
That was the
brought up
direction
by
they
the
were going.
Rotary Club of Eldred. So that, we learned that from Eldred. Okay, so I'm going to make a motion. My motion is that the International Committee recommends to the board that we as a club and members of the club spend $10,000 to pay for 3-day, 150-person individual training for community health promoters. And that funds include travel, lodging, training materials, transportation, food, space rental, 10 computers, and internet subscription, ballpark $10,000. So that's the motion. We have a second.
Comments, so discussion.
Yeah,
Let's have a quick discussion about that. Anybody with questions or thoughts about it?
Yes, take place in Kenya, and I'm proposing that we do this.
Collaboration with Eldred, Rotary Club.
What's that?
In collaboration with the Rotary Club in Eldridge, right?
I think we'd like to have their collaboration and have their involvement, yes, but in terms of the money would go through our club, through the Bloomington Rotary Foundation, and the check would come from the Bloomington Rotary Foundation to AMPATH. That's how the dollars. Yes, so any more discussion? Okay, all in favor, say aye.
Aye. Raj, what do you think?
Aye.
Okay, good. He's got an eye
Do we
from
have any
Raj.
opposed? Okay.
Fantastic. A round of applause. Yay. This is great. This is great. Great. Fantastic. Thank you. Thank you so much. And Steve, thank you for your leadership on navigating us through all of
and
this.
you-
Yeah.
The three of you helped us get to a point, we were 90% of the way there. You got the final.
So we want to take a picture. Should we all get up and have a picture with Raj? Yeah. Okay. And Raj, we're gonna
I don't see you guys. Zoom.
before you go,
blocked
Raj,
me.
we're gonna take a picture.
Do you see me?
Yes, I can see you in full screen. So I'm gonna
Okay.
a person standing next to me here.
Hey, I just have to say one thing. Thank you very much for Steve, and thank you the committee for coming to a decision.
Okay, thank you. I'll tell you. Raj says thank you to all. I'll tell them in a second.
Here, come.
Okay, here we go. And Raj, Raj has just expressed his thanks to Steve and to the rest of the committee for making a decision. Okay, Raj, we're going to take a picture of you here.
Oh, look at this guy too.
Yeah. Okay, Raj, you have to smile, Raj.
Young people.
Smile, Raj. Okay, great. Fantastic. We'll make sure that we send you that picture.
I would love
Okay.
to. Thank you. Have a
Okay.
good day, everyone.
We'll talk soon. Bye-bye.
Bye-bye.
Bye-bye.